Welcome back. Um, Advanced Frameworks, Leadership, Resilience, and the Haddon Matrix. In Lecture 1, we built the foundational understanding of why theory matters and explored several core frameworks: decision theory, economic models, crisis theory, and the Crisis Conceptual Model of Nursing. Today, we're going to advance the foundation by examining three critical areas that are especially relevant for nursing scholars: crisis leadership theory, resilience, and vulnerability frameworks, and the practical applications of these three-dimensional Haddon matrix. By the end of this hour, you'll have a comprehensive toolkit for designing theoretically grounded disaster research that's both rigorous and policy relevant. So let's dive in. Today's learning objectives are, first, that we're going to analyze 6 core attributes of crisis leadership and their relevance to nursing practice and research. Second, distinguish between resilience-oriented and vulnerability-oriented frameworks and understand when each is most appropriate. Third, apply the three-dimensional Haddon's matrix to evaluate disaster interventions using explicit value criteria. Fourth, to synthesize multiple theoretical frameworks to design a coherent, multi-level research study. And fifth, to critically evaluate how theory translates into policy recommendations and practice guidelines. These objectives will push you to think like doctoral level scholars who can navigate complexity and make theoretical choices that are both intellectually defensible and practically meaningful. Before we move forward, let's quickly recap where we've been. In Lecture 1, we established that theory is your lens. It determines what you see, what you measure, and what you conclude. We explored individual level theories like decision theory, systems level theories like the Haddon's matrix, and nursing specific models like the CCNM. And today we're kind of zooming in on leadership because disasters don't manage themselves. They require human coordination, well, at least for now, and decision making. We're also exploring resilience and vulnerability, which represent two fundamentally different ways of thinking about disaster risk. And we're going to practice using Haddon's matrix as a decision-making tool, not just a descriptive framework. So this is where theory becomes action. Let's start with crisis leadership. First, let's be clear about what crisis leadership is and what crisis leadership is not. I bet when I say leadership, everybody immediately starts thinking about leadership qualities. But when you add crisis in front of it, what does that mean? Crisis leadership is not the same as crisis management. Crisis management is about examining plans, coordinating resources, and maintaining operations. It's really tactical. Crisis leadership is strategic and relational. It's about creating vision during chaos and mobilizing people under extreme stress and building trust when information is uncertain and shaping organizational cultures so that teams can adapt and improvise. In nursing context, crisis leadership shows up at every level. The charge nurse coordinating an emergency department during a mass casualty event. The nurse manager relocating staff during a pandemic. the chief nursing officer advocating for resources and policy changes. As a researcher, we need those frameworks to study what makes crisis leadership effective. As nurses practicing today, we all saw these things during COVID. We saw them up close and personal. We know what they are. We can recognize what this means. Based on evolutionary concept analysis, a rigorous method for synthesizing literature across disciplines, researchers have identified 6 core attributes of crisis leadership. Let me walk you through them. First, clear, fast, and frank communication. Second, high collaboration across teams and organizations. Third, information sharing, making data accessible and transparent. Fourth, decision-making and fair prioritization under uncertainty. And fifth, trust building with staff, patients, and the public. And 6, competency, both technical expertise and adaptive capacity. Notice that there aren't personality traits. They're behaviors and practices that can be learned and improved. For nursing researchers, this gives you a concrete framework for studying leadership, interventions, and outcomes. So let's unpack the first attribute, communication. In a crisis, communication must be clear. It needs to be free of jargon and ambiguity. It has to be fast because delays create information vacuums that fill with rumors and panic. And it must be frank, honest about what is known and what is unknown and what is being done. I think that we can all again remember COVID, and we could probably apply our experiences to COVID to each and every one of these. We can give you good examples and we can give you horrendously bad examples. Research from MERS and SARS outbreaks showed that when nurse leaders communicated transparently about risk and proactive measures, staff experienced less anxiety and greater willingness to work. Conversely, when communication was delayed and kind of sugar-coated, trust eroded and turnover increased. For your research, this means measuring not just whether communication happened, but its quality, timing, and its perceived honesty. So we also know that that we have a lot more research to do. So attribute 2, the second attribute is collaboration. Disasters are inherently multi-sectoral, which means they require coordination across health, public health, emergency management, government agencies, and community organization. Crisis leaders must break down the silos that exist. They have to build partnerships and they need to create shared situational awareness. In nursing, this might mean collaborating with physicians, respiratory therapists, social workers, community health workers, and others to coordinate patient care. It also means collaborating with external partners, like public health departments and emergency operations centers. Research shows that high collaboration is associated with better resource allocations, faster problem solving, and more equitable outcomes. But collaboration is hard. It requires trust, it requires shared goals, and often it requires formal structures like incident command systems. And ICS is not a language that most nurses speak, but we need to learn it if we're going to work in disasters. The third attribute is information sharing, which goes beyond communication. Information sharing means making data accessible, transparent, and actionable for all stakeholders, not just top leadership. During COVID-19, hospitals shared real-time data on bed capacity, PPE supplies, and staffing levels with frontline nurses that empowered those nurses to make better decisions and advocate for their patients. Hospitals that hoarded information or only shared it upward created frustration and disengagement. For researchers that attribute highlights that this attribute highlights the importance of studying information systems, data governance, and the flow of knowledge during a crisis. It also raises questions about equity. Who has access to the information and who's left in the dark? And remember, one of the first lessons I learned in emergency management when I was running a command center was sending an email does not mean someone received the information. During COVID, leadership sent a boatload of emails. Do you think the nurses during COVID had time to read all those emails? Sending an email does not mean the communication was received. It might have made a leader's life easier to say, oh, look, I did something. But it is not the most efficient way to send information to nurses during a disaster. The fourth attribute is decision-making and fair prioritization. In disasters, resources are scarce, or they can be. Time is limited and decisions have life or death consequences. Crisis leaders must make decisions quickly, often with incomplete information, and they must prioritize in ways that are perceived as fair. This is where theory from Lecture 1 comes back. Are you prioritizing based on utility or justice? Research shows that when prioritization processes are transparent and involve input from the affected stakeholders, from the community, they're more likely to be accepted, even when the outcomes are painful. For nursing research, this means studying triage protocols, resource allocation, logarithms, and the ethical frameworks that guide decision making. The fifth attribute is trust building. Trust is the currency of crisis leadership. Without trust, people won't follow your directives. They won't share information and they will not collaborate. Trust is built through consistency, competency, transparency, and empathy. Research from the disaster context shows that trust in leadership predicts compliance with public health measures, with willingness to work in high-risk environments, and with long-term organizational commitment. But trust is fragile, and we all know that. It takes years to build trust, and it only takes moments to destroy it. For nursing researchers, this means studying the antecedents of trust, the mechanisms by which it's built or eroded, and its consequences for health outcomes and workforce retention. The sixth and final attribute is competency. Crisis leaders must demonstrate both technical competence, which is knowledge of clinical care, public health, and emergency management, and adaptive competence, and which is the ability to improvise, to learn, to adjust in real time. Competency also includes emotional intelligence and cultural humility. Research shows that when nurses perceive their leaders as competent, they experience less moral distress, greater job satisfaction, and better patient safety outcomes. Conversely, when leaders are seen as incompetent or out of touch, staff disengage and patient care suffers. For your research, this means measuring not just credentials or experience, but perceived competence and its impact on team performance. Now let's zoom out a little and let's look at the bigger picture. Crisis leadership doesn't happen in a vacuum. It has antecedents and it has consequences. Antecedents are the conditions that enable or constrain crisis leadership. They include things like social and environmental factors, like organizational culture, resource availability, and pre-existing relationships, as well as psychological factors like leader self-efficacy and stress tolerance and prior training. Consequences are the outcomes of crisis leadership. They include health promotion, so better patient outcomes and population health, and patient safety, fewer errors, better quality of care. Understanding antecedents and consequences allows you to design interventions that strengthen leadership capacity and measure impact of leaders on outcomes that matter. Now, let's ground this in nursing practice. During MERS outbreaks in South Korea, nurse leaders who demonstrated the six core attributes: clear communication, collaboration, information sharing, fair decision making, trust building, and competency, had teams with lower burnout and higher retention. During SARS outbreaks, hospitals where nurse leaders were excluded from decision making saw higher staff turnover and worse patient outcomes. And during COVID, nurse leaders who advocated for PPE, transparent data, and mental health support became trusted voices, not just because they're within their organizations, but in their communities. It didn't matter that nurses may not have had time to access mental health support. It mattered that the leaders advocated for it. These examples show that crisis leadership isn't abstract. It's measurable, it's consequential, and it's a legitimate focus for doctoral level nursing research. So now let's shift to a different theoretical tension here: resilience versus vulnerability. You saw a little bit of resilience and vulnerability discussed in the first chapter of the book. These are two fundamentally different ways of thinking about disaster research, and they lead to very different research questions and policy recommendations. Resilience frameworks focus on strengths, adaptive capacity, and the ability to bounce back. They ask what enables individuals, communities, and systems to withstand and recover from disasters. On the other hand, vulnerability frameworks focus on weakness, exposure, and susceptibility to harm. And they ask things like, who is at most at risk and why? Both are valuable, but they lead to different conclusions. Resilience frameworks can sometimes blame victims. If you didn't bounce back, you weren't resilient enough. Vulnerability frameworks can sometimes be deficit focused, ignoring community strengths. As researchers, you need to be intentional about which lens you are using. Resilience-oriented frameworks emphasize assets, resources, and adaptive capacity. They study social capital, community cohesion, economic resources, and institutional capacity. Resilience research often focuses on what works. So it focuses on successful recovery stories and effective interventions and protective factors. For nursing, resilience frameworks might guide research and nurse well-being. It might guide coping strategies or organizational supports that prevent burnout. The strength of resilience frameworks is that they are empowering and they are solution focused. The limitation is that they can overlook structural inequalities and place the burden of adaptation on individuals and communities rather than addressing the root cause of vulnerability. Vulnerability-oriented frameworks, on the other hand, emphasize exposure, susceptibility, and structural inequalities. They study poverty, discrimination, lack of access to resources, and historical marginalization. Vulnerability research often focuses on disasters. So it looks at who is harmed and why. For nursing, vulnerability frameworks might guide research on health disparities or barriers to care or social determinants of disaster outcomes. The strength of the vulnerability framework is that they center equity and justice and they push for structural change. The limitation is that they can be deficit focused and may not capture the community strengths or the community agency. The best disaster research often integrates both frameworks. So you can acknowledge vulnerability and at the same time recognize the importance of resilience. Now let's return to the Haddon Matrix and go a little deeper into the third dimension. So remember the value criteria. Remember, the first two dimensions are the time phases, pre-event, post-event, pre-event, event, and post-event, and the factors, host, agent, physical environment, and social environment. And then the third dimension asks us, how do we evaluate and prioritize the interventions? Carol Runyon identified 7 key criteria. Effectiveness, so does the intervention work? Cost, is it affordable? Freedom, does it restrict individual liberty? Equity, does it reduce or exacerbate disparities? Stigmatization, does it harm vulnerable groups? Community preferences, do affected populations support it? And feasibility, is it technologically, politically, and logistically possible? And I think this one is really, really important. It doesn't do us any good to come up with solutions that look good on paper or in a lab and are not going to work in the real world. So let's walk through how to use this in practice. Okay, So here's how to use the three-dimensional Haddon Matrix as a decision-making tool. Step one is to define the problem and fill in the two-dimensional matrix with the potential interventions. Step two is to identify and define your value criteria, which are, which of the 7 are the most important in this context. All right, so you may not have all of them, but which are most important? And then step 3 is to weigh the criteria. So are some more important than others? For example, is resource poor setting, is a resource poor setting more important? Cost might be weighed heavily in such a setting. In a community with a history of discrimination, equity might be paramount. Step 4 is to assess whether interventions, is to assess the intervention against each of the criteria. And step 5 is to compare the interventions and make a recommendation. The key is that this process makes your values explicit and your decision-making transparent. It's not expert opinion. It's systematic, and it is a defensible process. As doctoral level scholars, you won't use just one theory. You'll synthesize multiple frameworks to address the complexity, the multi-level research questions that you're going to be asking. For example, you might use the CCM to organize your study across disaster stages, crisis leadership theory to examine organization factors, and vulnerability frameworks to identify at-risk populations, and the Haddon Matrix to evaluate interventions. This kind of theoretical integration really is sophisticated, but it's also necessary because disasters are complex and they are multi-level phenomenon. The key is to be explicit about how your theories relate to each other. You need to ask, are they complementary? Are they nested? Or are they addressing different levels of analysis? And you need to show how each theory informs specific aspects of your research. Well, let's bring it all together here. Over the 2 lectures, we've built a comprehensive understanding of major theoretical approaches in disaster research. We've explored decision theory, economic frameworks, crisis theory, and the Crisis Conceptual Nursing Model, crisis leadership and its 6 core attributes, resilience and vulnerability frameworks, and the 3-dimensional Haddon Matrix. We've seen how theory shapes research questions, study design, interpretation, and policy recommendations. And we've emphasized that as doctoral level nursing scholars, you have an obligation to be explicit, intentional, and critical about your theoretical choices. Theory is not window dressing. It's the foundation of rigorous, meaningful, and impactful disaster research. As you move forward with your own work, keep asking yourself, what is my lens? What am I seeing? And what might I be missing? And how can I use theory to create knowledge that reduces suffering and promotes equity? Thank you.